Hello, Doctor. So, Dr. Brony here, and I'm very glad that you are joining me today to study. Please make sure you send this link to as many friends as possible so they can, all enjoy this lesson as we prepare for our very important exam, MCCQE1. Today, as I promised you, we're going to do two things. The first one is the series we are running, where we are going through the various MCC questions which have been loaded for free, and we are using them as teaching points and learning points as well. So today we are going to move on to question 2. And the reason why we cannot cover so many questions at a time is I really want us to take our time because there are valuable lessons there. Okay. And the MCC puts this issue out that why should we attempt the free questions? Why should you attempt them? And for me, it's very critical. So if you've not tried them, make sure that you are trying those questions. And I'm going to drop the link in the comment section. Okay, I'm dropping the link right away in the comment section. Please, if you've not tried these questions, I plead with you, make sure you are trying them. Now, why does the MCC want you to try the questions? It says that these free questions reflect those on the MCCQE1 Part 1, and they offer a valuable glimpse into the expectations and standards of the exam. Okay, so please, this gives you, something for you to really appreciate so far as the exam is concerned. Now, so today we are going to go to question 2, and maybe you might have tried it. The essence of it is not just going through the questions, but learning the very, very important things you need to know so far as these topics the medical council is testing you on. So I'm going to run through the question, and after that we go to the teaching point so far as that question is concerned. So it says that you have a 25-year-old man who presents with a 2-month history of swelling, pain, and inflammation in his knee. He also reports chronic low back pain and morning stiffness for the past 2 years. Which one of the following is most likely to confirm the diagnosis? A, uric acid level. B, antinuclear antibody test. C, radiography of the sacroiliac joints. D, rheumatoid factor level. And E, synovial fluid analysis. What's the correct answer? So for this, the essence of these parts of the class is not to actually go through these questions, but to use the question to highlight important parts and important things we need to learn so far as the MCCQE1 is concerned. So what's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? So someone is asking, Dr. Boni, can you help me to record this class? No, this class is going to be on YouTube. You don't need to worry about it. It's going to be there all the time for you. So you don't need to worry about it. Okay. So the therapy and healing says the answer is C. Does any other doctor have any other answer? Dr. Rockefeller went for D. I need 8 more people to answer so that we get 10 answers. Then I can move on to the correct answer and what the medical council says. If you want to try these questions, please just click on the link I'm sharing in the comment section and you can try them right away. Okay. And don't forget to like and subscribe our YouTube channel. Okay. Good. So we've got 1, 2, 3, 4, 5 answers. Some are saying C, some are saying D. 6, 7, okay. So it looks like the competition is between C and D. And C is radiography of the sacroiliac joints, and D is rheumatoid factor level. I need 3 more people to answer so we can then go on. I need 3 more people to answer, then we can move on. This session is very simple to focus on the areas that the MCC is directing you to. Dr. Sabine went for C, okay? Okay. Dr. Gail Imeu went for C. One more person, one more answer, and then we move on. Okay, Dr. Salma went for D. The correct answer is C. 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 So now, what is the question highlighting on? So those who went for D, please, you want to pay attention and look at it. The correct answer is C, not D. Okay, C, not D. Now, this is the issue. This is a question again. A 25-year-old man, I'm going to make the question big, presents with a 2-month history of swelling, pain, and inflammation in his knee. He also reports chronic low back pain and morning stiffness for the past 2 years. Which of the following is most likely to confirm the diagnosis? A, uric acid level. B, antinuclear antibody test. C, radiography of the sacroiliac joint. D, rheumatoid factor level. And E, synovial fluid analysis. The correct answer is C, and this is the rationale. The clinical vignette, okay, this clinical vignette is suggestive of spondyloarthropathy. So if you've not reviewed spondyloarthropathy, those in MedCognito, you realize that if you go to your rheumatology and musculoskeletal portal, we've broken down all the spondyloarthropathies there for you, okay? Particularly ankylosing spondylitis. So that is a topic you cannot miss in your board exam because the medical council is testing you on it. They've given you a free question on it. So please write this down that today I am going to review ankylosing spondylitis. Make sure that today you review ankylosing spondylitis. You can't miss it in any board exam because the medical council has already given you a clue that they are going to test you on it. Okay. Now, radiography of the sacroiliac joints is crucial in confirming this diagnosis, as radiographs can reveal sacroiliitis, which is a hallmark of ankylosing spondylitis. So that is something you want to pay attention to. Now, this imaging can show changes such as joint space narrowing, sclerosis, or erosions, which are indicative of the disease. So this also teaches you that you must learn as part of your learning strategy, what are the X-ray features of ankylosing spondylitis? And today we are learning joint space narrowing, joint space sclerosis, joint space erosions. Okay, now why is uric acid wrong? Uric acid level is typically used to diagnose gout, which presents with acute joint inflammation but does not align with the chronic back pain and stiffness which is described in the question. So apart from ankylosing spondylitis, apart from X-ray features of ankylosing spondylitis, another topic I want you to write down and review today is gout. Please write it down and review it. Gout. Number 3, an antinuclear antibody test is more relevant for autoimmune conditions like lupus, which does not match the patient's symptoms. So another diagnosis I want you to learn today is lupus. So those in the MedCognito program, I want somebody to be typing these in the WhatsApp group right now. Type them in the WhatsApp group. I need somebody to be typing these topics I'm highlighting on because the medical council has given us all these clues. I'm going to review ankylosing spondylitis. I'm going to review X-ray features of ankylosing spondylitis. I'm going to review gout. I'm going to review how to diagnose gout and all the things which come with gout. So if you pick any of the topics, like I told you, every MCCQE1 topic has various components. How to diagnose that condition, the clinical features, investigations, management. And management, you're looking at pharmacologic and non-pharmacologic management options, complications, indications for referral. Okay, so please, ankylosing spondylitis, gout, systemic lupus erythematosus. Okay, and then rheumatoid factor level is associated with rheumatoid arthritis, which usually involves multiple joints symmetrically and does not typically cause low back pain. So another diagnosis I need to master for my MCQE1 exam is rheumatoid arthritis. So let me take it again. From today's class, what topics are we going to review? Number 1, ankylosing spondylitis. Number 2, systemic lupus erythematosus. Number 3, gout. Number 4, rheumatoid arthritis. Okay. Now, synovial fluid analysis is useful for diagnosing infections or crystal-induced arthritis, but does not provide information about sacroiliac joints or chronic back pain. Okay. Now, let's go beyond the way this question was put and look at what this question is actually testing. This is a signal question. When I say a signal question, what I mean is that this question is pointing you in a particular direction. Spondyloarthropathies. Okay, so it's a way that you can be tested on entire cluster of diagnosis, because in reality, you must learn how to differentiate gout from ankylosing spondylitis, from lupus, from rheumatoid arthritis. You must learn how to separate these. Okay, now the medical council wants to see if you can recognize inflammatory back pain. That's number 1. Number 2, they also want to see if, as a candidate, you can separate crystal arthritis from autoimmune diseases and spondyloarthropathies. Number 3, they want to know if you know how to choose that one best test which is used to diagnose ankylosing spondylitis, that one best test which is used to diagnose rheumatoid arthritis, that one best test which is used to diagnose lupus, rheumatoid arthritis, and all the other things like gout. And this test is also testing your ability on how to avoid ordering irrelevant or low-yield investigations. Because you realize that that is something we really emphasize on in our training at MedCognito. We tell you that, look, don't just go choosing things like that. No, because that is not how the healthcare system works, right? You want to come across as somebody who is very efficient in the way you manage patients, in the way you request investigations. And you must also recognize patterns across rheumatologic conditions. So, inflammatory back pain, what's the pattern? What's the pattern for inflammatory back pain? The key clues you must learn are: age of patients is usually less than 40 years. Usually, you may be presented with a patient with 3 months or more of back pain. This patient is presenting with morning stiffness more than 30 minutes a day. And usually that morning stiffness improves with activity. And usually when there is rest, it gets worse. When you see these features, doctor, please don't miss anything. Don't forget about spondyloarthropathies, especially ankylosing spondylitis. Now, there are clues to pick up from the question, and these are must-know concepts. So, number 1, write this down in your book. How am I going to separate inflammatory causes of back pain from mechanical causes of back pain? That's the first thing I want you to know. Number 2, how will I separate spondylitis from rheumatoid arthritis, from lupus erythematosus, from gout, and from septic arthritis? So these 5 diagnoses, even if you are asleep and someone wakes you up, you must be able to tell, okay, the features that I'm being given, I can be able to separate ankylosing spondylitis from rheumatoid arthritis. I can be able to separate rheumatoid arthritis from lupus. I can be able to separate rheumatoid arthritis from gout. I can be able to separate lupus from septic arthritis. Doctors, please, I want to ask, is this making sense? That is why for me, it's not just about, just solving questions. No. It's about taking a step beyond the questions and really learning what is this question testing, so that next time when a different question like that is brought up, I can be able to deal with it. Please, if it's making sense, type yes in the comment section before we move on. If it is making sense, just type yes. in the comment section before we move on. If it's making sense to you now, just type yes, 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 yes before we move on. Don't forget that we have the second part of today's class. Good. Okay. Now, know the real confirmatory test for spondyloarthropathy. That is radiography of the sacroiliac joint. You have to know that is what the question is testing you about. How am I going to, what's the real confirmatory test for ankylosing spondylitis? Radiography of the sacroiliac joint. Because I'll be looking for sacroiliitis, which is the hallmark feature of ankylosing spondylitis. Now, you must also learn the tests which are not useful. Okay, so you have to realize that when it comes to ankylosing spondylitis, uric acid is not necessary. ANA, if you request ANA, you are thinking about lupus. If you request rheumatoid factor, you are thinking about rheumatoid arthritis. If you request synovial fluid, you are looking for, is there any infection in the joint? Is there any gout? And even with gout, you must know what are the synovial fluid features of gout and what are the synovial fluid features of pseudo gout. You must know these two things. Because if you know what not to order, that is a very, very important MCQE1 competency you must master. And this is what brings us to the concept of choosing wisely. Because you know, every day I talk about choosing wisely Canada, choosing wisely Canada, choosing wisely Canada, choosing wisely Canada. And people don't know, look, I'm going to show you that this question was chosen from Choosing Wisely Canada. I'm going to show you something. So if you go to Choosing Wisely Canada, I'm going to share the link to Choosing Wisely Canada. Okay, it is one of the resources you need in, like the medical council has suggested that you need Choosing Wisely Canada to ace your QE1. Choosing Wisely Canada, very important resource that you need. Okay, and I'm sharing the link now. If you go to Choosing Wisely Canada, you realize that they have a whole section under rheumatology. Okay, rheumatology. Now, the rheumatology section, they have 11 things that they highlight on there. And I'm going to run through them quickly. The first one is, don't order ANA as screening test in patients without specific signs or symptoms of systemic lupus erythematosus or another systemic autoimmune rheumatoid disease. That's the first thing, which is on Choosing Wisely Canada, rheumatology. Number 2, don't order an HLA-B27 unless spondyloarthritis is suspected based on specific signs and symptoms. Number 3, don't repeat dual energy X-ray absorptiometry, which is the DEXA scan, more often than 2 to 3 years in individuals at high risk for fracture and or receiving anti-resorptive therapy. Number 4, don't prescribe anti-osteoporotic therapy to patients at low risk of fracture. Number 5, do not perform whole body scans for diagnostic screening for peripheral and axial arthritis in adults. Number 6, don't prescribe opioids for the management of chronic rheumatoid disease before optimizing the use of non-opioid approaches and to pain management. Now, this is the part which is very sweet to me. Next one, do not delay or avoid palliative symptom management and advanced care planning for a patient with life-limiting rheumatic disease because they are pursuing disease-directed treatment. Number 8, do not order labs for drug toxicity monitoring more than every 8 to 12 weeks for patients on a stable dose of non-biologic disease monitoring anti-rheumatoid drugs like DMARDs in patients without comorbidities or lab abnormalities. Now, this is where the number 9 is very important. Do not order rheumatoid factor or anti-CCP or anti-citrullineated protein antibody unless patients have clinically suspicious arthralgia or arthritis on the exam. The next one, do not perform serologic imaging or genetic testing without checking for and considering past available results. And last but not the least, don't dispose of regular waste in a biohazardous waste container when performing joint aspirations or injections. Doctors, please, choosing wisely Canada is very important. So if you had known 0.9 and if you had also known 0.1 and 2, this question would be easy. This question would have been easy. This question would have been super easy. So somebody's asking, so can we order HLA B27 in this question? Yes, from choosing wisely. However, you realize that the question did not highlight HLA B27 in the question. So don't even worry about it. Don't try to think in a highfalutin sense. Doctors, I'm using this question from the Medical Council itself and a resource that they directed us to, which is Choosing Wisely Canada, to let you know that, look, we have to use the right resources in order to ace this exam. And for those in MedCognito, you realize that we've set numerous questions on Choosing Wisely Canada alone. Please go to your mock portal. Those questions are there. Make sure you solve them. Okay, so I'm trying to wrap up on this before we go to the next section. Based on this question which we just did, topics that we need to review are, number one, ankylosing spondylitis. If you've not reviewed it, please go back and review it. Number two, psoriatic arthritis. Number three, reactive arthritis. Number four, inflammatory bowel disease related arthritis, because you realize that in patients with inflammatory bowel disease, they have non-GI manifestations of the disease. Some factors which can affect the eye, even the heart, the skin. You must know all these things. You must know them. Another thing you have to review are lab investigations and other things which come with it. So, which conditions are associated with HLA-B27? Which rheumatologic conditions are associated with uveitis? Which rheumatologic conditions are associated with enthesitis? Which rheumatologic conditions are associated with dactylitis, where somebody develops puffy fingers? Which rheumatologic conditions are associated with sacroiliitis? And which rheumatologic conditions are negative for rheumatoid factor and ANA? Doctors, please, I want to pause here. Am I making sense, please? Am I making sense? I want to know if I'm making sense. Just type sense. I want to know, am I making sense? Doctors, please, am I making sense? This exam is not just about, oh, I picked the book and I read it. No, these are the nuances you must learn. Please, am I making sense? Okay, good. So I'm getting good response. So doctors, you see why Dr. Rockefeller, the last time you were saying, oh, we should solve maybe 2 or 3 questions at a time. Look, only one question has taken us almost 30 minutes. Because for me, like the way I trained and the way I want to train my candidates, it's not just about, oh, we've solved questions. But I want us to look beyond the question and look at what is the Medical Council really drawing your attention to. Okay, so you have to learn some of the extra articular manifestations of spondyloarthropathies, like uveitis, where a patient comes in with joint pain and you are told that the patient has a red, painful eye with photophobia. Number 2, aortic regurgitation, where they can have chronic inflammation, so it can lead to aortitis, right? And then we are looking at another extra GI manifestation, like restrictive lung disease. So in patients with spondyloarthropathies, at times they can have restrictive lung disease, where they may present a shortness of breath and reduced chest expansion. And do not forget to also learn the management of all the conditions. So rheumatoid arthritis, learn the management, complications of the management, first line, second line management. Gout, learn the management. Ankylosing spondylitis, learn pharmacologic, non-pharmacologic management. Lupus, learn pharmacologic, non-pharmacologic management. Complications. What's the role of physiotherapy? What's the role of TNF alpha inhibitors? What are the first line treatments? What's the role of NSAIDs? Is there a role for opioids at all in these conditions? Doctors, these are the things that I want you to master as a MedCognito candidate. It's not just about somebody reading a book like Toronto Notes to you. No. Many people, they'll come, Dr. Bruni, I went for this course and they were just reading Toronto Notes to me, or they were just reading Master the Boss to me. These are wonderful resources, but it's not just about that. It's about taking time to break these concepts down so that you really know what you are being tested on. Okay, so learn extra articular manifestations of the various spondyloarthropathies. Please. All right. So, quick point. I'm going to just review them quickly and then we'll be done. So, when it comes to ankylosing spondylitis, look for a young person who is presenting with back pain and morning stiffness. It gets better as the day goes by. It gets worse when the person rests, and the person may present with sacroiliitis. That's ankylosing spondylitis. Number 2, reactive arthritis or Reiter's syndrome. Look for a patient who had either a genitourinary or gastrointestinal infection, and the person has now developed joint pains and joint swellings after that. It presents with a triad: arthritis, conjunctivitis, and urethritis. So that is Reiter's syndrome for you. Psoriatic arthritis, what will you see? You will see nail pitting in that patient. You will see some skin plaques, and then you may see some dactylitis as well. And then rheumatoid arthritis, look for symmetric small joint involvement. Rheumatoid factor will be positive or may be positive, and you can check anti-CCP as well. And then the last differential I want you to learn will be gout. Sudden attack, usually on the big toe. High uric acid is not diagnostic, because you can have some people who may even have an acute flare-up of gout and their uric acid will be normal. Doctors, please, this is my information for you. So, what are the summary points we need to learn from question 2? Inflammatory back pain, what are the red flags? Sacroiliitis, that is radiographic features of sacroiliitis and ankylosing spondylitis. What conditions are seronegative spondyloarthropathies? Okay. What are extra articular manifestations of these rheumatologic conditions? Uveitis, aortic regurgitation, restrictive lung disease. And then I want you to learn how to differentiate between rheumatoid arthritis, gout, systemic lupus erythematosus, and septic arthritis, as well as how to select specific tests for specific conditions, so that you don't just choose any test anyhow, using the choosing wisely concept. And please, if you don't have the link to the choosing wisely, I'm going to share it right again. Choosing wisely, I'm just sharing choosing wisely rheumatology. Choosing wisely rheumatology. Okay? Doing that right now. And avoid wrong investigations in patients with rheumatologic conditions. So, doctors, this is the end of part 1. I'm going to stop this stream and then we jump on to the next stream. So come back to the YouTube channel, because I'm going to go on to the second class for today. But please, I have a question. Did it make sense? Did it make sense? And if you want to talk to me, that's my phone number after this. You go like, hey, Dr. Bruni, today you've thrown too much light on this thing. It's even shining my eye. It's shining my eye. 306-891-5649. 306-891-5649. 306-891-5649. That's my phone number. That's my personal phone number. It's not my assistant who will pick it. It's not somebody who will pick it. That is my phone number. That is Dr. Bruni's phone number. Give me a shout out after this. And then if you want to join on our program, join. But please remember, this is just the part 1. We are coming to the part 2. So I'm going to end this and then we jump on to part 2. See you.